to the class. It's so fast online. Teacher go home, and I come from the clinical laboratory of Fujian Medical University Union Hospital, and this is my email. If any question about this class, please don't hesitate to contact me. Okay, let's get started. Today the topic is about laboratory diagnostics. It contains 3 sections. First, principles of diagnostic test use and interpretation. Second, blood cell parameters. Third, blood cell morphology examination and anemia. Okay, let's get into the first part, principles of diagnostic test use and interpretation. First, there's a question. What is laboratory test? It is a medical procedure that involves testing a sample of blood, urine, or other substance from the body. Laboratory diagnosis or laboratory test refers to using specimens collected from human's body, includes blood, body fluid, secretion, and excrement, select a suitable reagent, instrument analysis, and quality control, system management, and then get the accurate results. The results are provided to physicians and other healthcare professionals with information like disease diagnosis, differential diagnosis, and guide for treatment, and monitor efficiency of therapy, or prognosis assessment, prevention of disease, or conduct scientific research. Laboratory tests can help determine diagnosis, plan treatment, check to see if treatment is working, or monitor the disease over time. Okay, the next question. How do I interpret my test result? Here, before I answer this question, here I want to introduce a few terms: normal range, reference interval, and reference value. It means the characteristic of 95% of values from a normal population. With some laboratory tests, the results obtained from healthy people can vary somewhat from person to person. In fact, the results obtained from a single person given the same test on different days can also vary. For these tests, therefore, the results are considered normal if they fall between certain lower and upper limits or values. This range of normal values is known as the normal range, reference interval, or the reference value. When healthy people take such tests, it is expected that their results will fall within the normal range 95% of the time, while 5% of the time, the results from healthy people will fall outside the normal range and will be marked as abnormal. Reference ranges are based on test results from large numbers of people who have been tested in the past. So what if your lab results are abnormal? Does it mean you are unhealthy or sick? The answer is no. There are many factors that can affect the result of a lab test: your sex, age, and race, what you eat and drink, medicines you take, or how well you followed pre-test instruments, and so on. So if you got an abnormal test result, you have to check if there are factors that affect the test results. The best way is to do a second test after controlling the influencing factors. Okay, let's get into the next part, red blood cell parameters and clinical significance. The Nobel Prize in Physiology or Medicine in 2019 was awarded to the 3 scientists for their discoveries of how cells sense and adapt to oxygen availability. Red blood cells, or erythrocytes, have many important physiological functions. Red blood cells are the most common type of blood cells. The primary function of red blood cell is to carry oxygen from the lungs to body tissues and to transfer carbon dioxide from the tissue to the lungs. The cytoplasm of erythrocytes is rich in hemoglobin, an ion-containing biomolecule that can bind oxygen and is responsible for the red color of the cells. Approximately 2.4 million new red blood cells are produced per second. Red blood cells develop in the bone marrow and circulate for about 120 days in the peripheral blood before their components are recycled by macrophages. So the box and the picture below I show here here shows the growth and the development of red blood cells. The 4 green boxes shows the development of red blood cells in the bone marrow. That is pronoblast, oligoblast, polychromatic noblast, and also chromatic noblast. And the red box shows the mature erythrocytes in the peripheral blood. Yes, that's the normal red blood cells. And the yellow box shows the reticulocyte. It is the transition phase of red blood cells. And reticulocyte is an important cell for clinical application, and I'll explain it later in the later PPT. Oh, here I wanna say this erythropoietin EPO. EPO is the most important hormone that promote red blood cell production. That's useful use. That's useful use in the scientific research. Okay. Now let's learn red blood cell parameters, red blood cell count, and hemoglobin. Red blood cell count is the number of red blood cells per unit volume of blood. It is to evaluate the number of red blood cells per liter blood. together with the hemoglobin concentration, the amount of hemoglobin per unit volume of blood, and red blood cell count together with the hemoglobin is used to screen for disease associated with anemia, determine the severity of anemia, and observe the response to treatment for anemia. The reference interval of red blood cell and hemoglobin concentration I have shown below for adult male and adult female. Yeah. Please pay attention to the unit. For red blood cell, the unit is times 10 to the power of 12, while for hemoglobin concentration, the unit is gram per liter. Here, increase in red blood cell and hemoglobin concentration means red blood cell count is more than 6 times 10 to the power of 12 per liter. Hemoglobin concentration is more than 170 in adult males, while for adult female, red blood cell count is more than 5.5. Hemoglobin concentration is more than 160, and that means the red blood cell count and hemoglobin concentration is increasing. Increased hemoglobin concentration and red blood cell count can show in physiological conditions and pathological conditions. For example, the people live in high altitude while they have high red blood cell count and hemoglobin, while pathologic conditions associated with increased red blood cell and hemoglobin. For example, in the polycythemia vera is a disease of unknown origin that results in an abnormal increase in red blood cells, or pulmonary disease, or congenital heart disease, or kidney tumors, and etc. In this disease, the patients may have increased red blood cell and hemoglobin concentration. Okay, the next parameter, hematocrit. Hematocrit, the conception of hematocrit, shown as HCT, is the ratio of the volume of thinking red blood cells in whole blood after centrifugation of anticoagulated whole blood. It is the ratio between the volume of packed red blood cells and the volume of whole blood in a sample of capillary or venous blood. The HCT is measured after appropriate centrifugation and is mainly related to the red blood cell mass and the plasma volume. In this picture, you can see, and this section is the plasma, and this section shows the hematocrit. The normal range for hematocrit is different between the sexes. For male, it is 40% to 50%. For female, it is 35% to 45%. Okay, now let's learn the average red blood cell parameters. MCV mean corpuscular volume, MCH mean corpuscular hemoglobin, and MCHC the mean corpuscular hemoglobin concentration. The three parameters I'll explain them one by one. MCV, it means the average volume of each red blood cell. We take FL as the unit. Cells of normal size are called normocytic. Smaller cells are microcytic, and larger cells are macrocytic. The reference interval for adult is 82 to 100, and for infants is 86 to 120. And the formula of MCV equals hematocrit be divided by numbers of red blood cells per liter. And MCH, mean corpuscular hemoglobin, is the average value of hemoglobin concentration in each red blood cell. We take PG as the unit. And the reference interval for adult is 27 to 34 pg, and for infants is 27 to 36 pg. And the formula for MCH equals hemoglobin be divided by red blood cell counts. While MCHC means corpuscular hemoglobin concentration, it is the concentration of hemoglobin contained in each liter of red blood cell. We express it in gram per liter. And the cells with a normal concentration of hemoglobin are called normochromic. Cells with a lower than normal concentration are called hypochromic. And the reference interval for adult of MCHC is 320 to 360 gram per liter, and for infants is 250 to 370 gram per liter. And the formula to calculate MCHC is hemoglobin concentration divided by hematocrit. The clinical significance of the three red blood cell parameters, MCV, MCH, and MCHC, is that the three parameters can help us to turn the anemia morphology classification. Here I will, okay, this part I will explain it later. First, let's learn the next parameter, RDW, red blood cell distribution wise. Red cell distribution wise, RDW, is a parameter that measures variation in red blood cell size. Usually, red blood cell, usually RDW is indicated by a CV, coefficient of variability, and the reference interval of ITW CV is between 11.5% to 15.4%. And the clinical significance of ITW is that ITW is that ITW combined with the examination of MCV can help us to give the morphological classification about anemia. Yeah. For example, a decreased MCV and a normal ITW may show microcytic isocytic anemia. It can be seen in the beta thalassemia minor anemia, while increased MCV and normal ITW, and decreased MCV and an increased ITW, it is a microcytic anisocytic anemia, while it can be seen in the iron deficiency anemia. Now let's learn the clinical significance of reduced red blood cells and hemoglobin concentration. Decreased red blood cell counts and hemoglobin can be seen in physiological condition in children, middle and late pregnancy, the elderly. The red blood cell count and hemoglobin is decreased. While in pathological condition, reduced red blood cells and hemoglobin may be in some disease condition. For example, decreased red blood cell production, excessive destruction of red blood cells, or excessive red blood cell loss. Decrease in red blood cell count and hemoglobin concentration. According to the level of hemoglobin, anemia can be classified as mild anemia. Hemoglobin concentration is in 90 to 120 gram per liter. Medium anemia means hemoglobin is less than 90 gram per liter and more than 60. And severe anemia, that means the hemoglobin is between 30 to 60. And extremely severe anemia, that means the hemoglobin is less than 30 gram per liter. Physiological conditions associated with increased red blood cell count and hemoglobin concentration. First, at high altitude, less atmospheric weight pushes air into the lungs, which causes hypoxia and a decreased pressure of oxygen. Increasing red blood cell production occurs in order to compensate for the low oxygen levels and inadequate tissue oxygenation. Second, strenuous physical training increases muscle demand for oxygen and increases release of red blood cell from bone marrow. And the third, smokers also have a higher number of red blood cells than non-smokers. While the absolute increase of red blood cells and hemoglobin can be seen in the EPO increase in blood. It contains two kinds of EPO increasing, compensated or non-compensated. For example, kidney tumors. The tumors in kidney produce excess EPO, erythropoietin, which is used to stimulate the production of red blood cells from the bone marrow. So the red blood cell counts and hemoglobin are all increasing. And another kind of increase of red blood cell counts and hemoglobin can be seen in polycythemia vera. Okay, now let's move on to the next part, white blood cell parameters and clinical significance. White blood cells, also called leukocytes, play an important role in the immune system. They destroy and remove old or aberrant cells and cellular debris, as well as defend the body against both infectious agents and foreign substances. White blood cells are bigger than red blood cells, but fewer in number. When acute infection occurs, the number of white blood cells rises very quickly. And the reference interval of white blood cells in peripheral blood is for adult is between 4 to 10 times 10 to the power of 9 per liter. While the clinical significance of white blood cells means that the number of white blood cells is above 10 times 10 to the power of 9 per liter, whereas the number of white blood cells below 4 times 10 to the power of 9 per liter is considered to leukopenia. The chance of number of any types of white blood cells will affect the total white blood cell count. So the detail of clinical significance of total white blood cell count I will show on the next pages. What are the changes of white blood cells or granulocytes of COVID-19? Yeah, there are several changes of white blood cells in COVID-19 infectious patients. First, the total number of white blood cells in peripheral blood is normal or decreased in the early stage. And the COVID-19 infectious patients have the decreased lymphocyte count. In severe cases, the number of peripheral blood lymphocytes gradually decrease, while CRP is elevated in most patients. Here, please pay attention to CRP, and I will show it after. Actually, based on different morphological characteristics, the white blood cells are divided into three types: granulocytes, lymphocytes, and monocytes. But according to the specific granules, granulocytes are divided into neutrophilic granulocytes, eosinophilic granulocytes, and basophilic granulocytes. Mm, Neutrophilic granulocytes are the largest proportion of them because leukocytes have different functions. The numbers and morphology of each type of leukocytes give important information for the diagnosis of disease. The different white blood cell count can be expressed as a percentage or an absolute count, which is obtained mathematically. And this table shows the reference value of peripheral blood leukocyte classification ratio. Uh, and this column shows the percentage, and this column shows the absolute number of all kinds of white blood cells. Here I want to say there are only mature white blood cells in peripheral blood, and neutrophils only have stab-shaped and segmented-shaped nucleus stage. Among the white blood cells, the most common leukocytes are neutrophils. The neutrophilic granulocytes have 6 developmental stages: myeloblast, promyelocyte, and metamyelocyte, step and segmented neutrophils. Only step and segmented granulocytes migrate to the peripheral blood. The main function of neutrophilic granulocytes is responsible for protecting our body from infections. Neutrophils migrate towards the sites of inflammation. They can activate phagocytes to engulf foreign material and organisms. Neutrophilia refers to the number of neutrophilic granulocytes more than 7 times 10 to the power of 9 per liter. Physiological conditions associated with neutrophil. There are neutrophils are as shown in the upper box. Um, the number of white blood cells in peripheral blood is fluctuation during the day. It is higher in the afternoon than in the morning. Full meal, excited emotions, exercise, high temperature, severe cold, etc. Newborns, menstrual period, more than 5 months of pregnancy, and all these conditions can result in physiological neutrophilia. Uh, Here I want to say all these conditions, all these changes of neutrophil are always transient. Usually, the quality of neutrophil doesn't change. But a pathological condition, there are I show the change of leukocytes. Uh, but the pathological change of neutrophilia can be seen in acute infection, especially gram-positive cochlear infection, and severe tissue damage, severe trauma, extensive burns, and massive blood cell destruction. Uh, and acute hemorrhage, acute poisoning, leukemia, malignant tumors, leukemia-like reactions. Neutropenia. Neutropenia refers to the number of neutrophilic granulocytes less than normal. Or the absolute value of neutrophils is lower than 1.5 times 10 to the power of 9 per liter. It's called granulocytopenia. The risk of infections increase considerably when the patient is granulocytopenia. Granulocytosis means the absolute value of neutrophils is lower than 0.5 times 10 to the power of 9. The most important thing you have to do for neutropenia is to identify the causes. What are the causes of neutropenia? First, infections, and I will explain infections that cause neutropenia later. Second, blood disease, aplastic anemia, some megaloblastic anemia, and certain types of leukemia. Physical and chemical factors, radiation, radionuclides, chemical materials, and chemical drugs, etc. Or hypofunction of the mononuclear phagocyte system, or hypospleen, autoimmune disease such as systemic lupus erythematosus. Infections that cause neutropenia, especially gram-negative bacilli infections, such as typhoid and paratyphoid infections. The total number of white blood cells and neutrophils are reduced. For certain viral infections, certain parasite infections, like Monoria caseata. This smear shows the acute promyelocytic leukemia. It is the peripheral blood smears. In this kind of leukemia, the patients have reduced white blood cells, and leukemia cells are not easy to be detected, and it is easy to miss and misdiagnosis. So I hope you to pay attention to this kind of leukemia. This picture shows the physiological increase of lymphocytes in childhood. Neutrophils are predominant in newborn babies, and the ratio of the two is similar by 4 to 6 days. Thereafter, lymphocytes gradually increase, and lymphocytes are higher throughout infancy. By the age of 2 to 3, lymphocytes gradually decline, and the neutrophils gradually rise. And by the age of 4 to 6 years, the two are basically the same. by 6 to 7 years old, it is similar to adults. So, guys, you should remember the two numbers, 4 to 6 days and 4 to 6 years, because in these two time, the lines are across the lymphocyte line and the neutrophil line and lymphocyte line. They have two cross point. Now we'll learn the lymphocytes. Lymphocytes are a type of white blood cells and protect the body against disease and fight infections. Lymphocytes are important parts of immune system and responsible for the immune responses. They are found in the circulation and also are detected in body fluid, in body tissues, such as the spleen, bone marrow, lymph nodes, tonsils, and liver. There are three main types of lymphocytes: T cells, B cells, and natural killer cells. T cells, accounting for 60 to 70% of lymphocytes, develop from bone marrow or liver stem cells that mature in the thymus. And the other 20 to 60% of lymphocytes are B cells, which develop from bone marrow stem cells in human. And natural killer cells represent approximately 10%. Now, the pathologic change of lymphocytes, first, the lymphocytosis. The definition of lymphocytosis is age-dependent. For adults, lymphocytosis means more than 4 times 10 to the power of 9 per liter, while for children larger than 4 years old, the reference interval of lymphocytosis means more than 7.2, and for the children less than 4 years old, the reference interval of lymphocytosis is more than 9. Many diseases and conditions are associated with lymphocytosis. First is the virus infection, for example, cytomegalovirus infection. Bacterial infection, such as tuberculosis, and hemolytic disease, such as aplastic anemia, granulocytopenia, and granulocytosis, and organ transplant can also be lymphocytosis. Lymphopenia. Many kinds of conditions and disease are associated with lymphopenia. Immunodeficiency, such as AIDS, HIV infections, the lymphocytes decrease, and the radiation, tuberculosis infection, and SLE. Eosinophilia refers to the number of eosinophilic granulocytes more than 0.5 times 10 to the power of 9 per liter, or the percentage in blood more than 5%. Conditions and disease associated with eosinophil are as follows. First, allergic disease, parasitic infection, malignant tumors like lymphoma, myeloproliferative tumors, etc. Please pay attention to allergic disease. This picture below shows a blood smear of peripheral blood. We can see there are so many the eosinophil in the blood smear because this patient his blood test results shows eosinophil. So we do re-examination. We made a blood smear and put it under the microscope. Then we found there are so many eosinophil. This one, they are eosinophil. Now let's move on to the next part, platelet parameters and clinical significance. Platelets are one of the 3 cellular elements of the blood. Its function, along with the coagulation factors, is to stop bleeding. Platelets have no nucleus. They are fragments of cytoplasm which are derived from the megakaryocytes of the bone marrow and then come into the circulation. In healthy individuals, approximately 1/3 of the entire platelets are stored in the spleen, while the remainder is present in the circulation. The platelet count is used to screen for or diagnose for various diseases and conditions that affect the number of platelets. The reference interval of platelet is between 130 times 10 to the power of 9. And here, please be remember the contraindication for surgery is 50. That means if the platelet count is less than 50, then the patient cannot be surgery. Now let's learn the clinical significance of thrombocytopenia. Platelet count in thrombocytopenia is less than 100. Platelet count below 60 may cause post-traumatic and post-operative bleeding, while platelet is less than 10 may be associated with spontaneous internal and external bleeding episodes. Pathological thrombocytopenia may be caused by platelet production disorder, increased platelet destruction or consumption, or abnormal platelet distribution. Here, I want to emphasize this reason, postural thrombocytopenia. It means this decreased platelet count is false. Because this false count is determined by the blood cell analyzer. Because of the platelet counting, for example, the EDTA-induced thrombocytopenia. If EDTA-induced thrombocytopenia is suspected, citrate should be used as an anticoagulant. This picture shows the EDTA-induced platelet aggregation. We can see in this picture, this is the platelet attached to the leukocytes. The EDTA-induced platelet aggregation, it means that platelets aggregate around the neutrophils in EDTA anticoagulant blood. It has nothing to do with drugs and disease. The blood smear shows abnormal platelet aggregation and reduced platelet count. Because the platelets attach to the surface of neutrophils and are not included in the count. It is recommended to switch to sodium citrate anticoagulation tube or other anticoagulation tube. Here is a clinical case. Female, the patient is female, 26 years old, with normal white blood cells count. The red blood cells is 4.2 times 10 to the power of 12 per liter, and hemoglobin is 95. MCV, MCH, MCHC are all decreased, and RDW is increased. The platelet is more than 1,000. The diagnosis is essential thrombocytopenia, thrombocythemia. And the patient is treated with hydroxychloroquine for 2 months. On a review, the patient reported that the platelets were sometimes normal, sometimes the same as the initial diagnosis, means more than 1,000. So the laboratories recheck platelet distribution. Like this blood smear shows, we can see this. There are fragments, and this small. There are so many red blood cells fragments. The blood cell analyzer mistake the red blood cells fragments for platelets. So finally, the patient is diagnosed with alpha thalassemia. Now let's move on to the next part, blood cell morphology examination. Now let's learn the normal morphology of red blood cells. The typical morphology of normal red blood cell is double concave disc shapes with the diameter of 6 to 9 micrometer. The average diameter is 7.2, and the color of cytoplasm is pink. The size of the central lightly stained area is about 1 to 3 to 2 to 5 of the cell diameter. Well, how many kinds of abnormal red blood cell morphology? We divided from the following 4 aspects: abnormal size, abnormal morphology, abnormal staining, and abnormal structure. First, abnormal size. Microcyte. Diameter of the cell less than 6 micrometer, and the center or least several of them disappear. Microcytes increase in iron deficiency anemia, sideroblastic anemia, and globinogenesis anemia. The next abnormal size is a macrocyte. Macrocyte means the diameter of the red blood cells is more than 10 micrometer. It can be seen in hemolytic anemia, acute hemorrhage anemia, and megaloblastic anemia. The picture shows the abnormal size. The blue shows the microcyte, and the yellow shows the macrocyte, and the red shows the macrocyte. Here, I want to say during the maturation of erythrocytes, the cells grow from large to small. Megalocytes. Megalocytes means the diameter of the red blood cell more than 15 micrometer. Megalocyte can be found in folate and B12 deficiency. That is the megaloblastic anemia. The next one is adipocytosis. It means the diameter difference can be more than doubled. It reflects that the erythroid hyperplasia in the bone marrow is obviously vigorous, especially in megaloblastic anemia. Next, let's learn the abnormal morphology together. First, spherocyte. In a blood, more than 20% of spherocytes have reference value for the diagnosis of hereditary spherocytosis. The next abnormal morphology of red blood cell is the target cell. It can be seen in globinogenesis anemia or thalassemia. and abnormal hemoglobin passes, and hemolytic anemia or iron deficiency anemia. The next abnormal morphology is the teardrop cell. It can be seen in myelofibrosis. Another abnormal morphology is schistocyte. This is a fragmented part of erythrocyte. The typical shape is irregular, jagged, and have two pointed ends. It is seen in the destruction of red blood cells due to mechanical or physical factors. Also seen in microangiopathic hemolytic anemia, such as diffuse intravascular coagulation, thrombotic thrombocytopenia purpura, and hemolytic uremic syndrome. Renal formation. Renal formation, it is the red blood cells are arranged closely and resembling a stack of coins. It can be found in multiple myeloma, primary macroglobulinemia, and abnormal red blood cell staining. The first type, hypochromic. It means excessive central pallor, more than one-third of its diameter in the erythrocyte. It is due to insufficient hemoglobinization. Hypochromia can be found in iron deficiency anemia, sideroblastic anemia, and globulin production disorder anemia. The next type of red blood cell staining is hyperchromic. Hyperchromic can be seen in the megaloblastic anemia and spherical red blood cells. The next kind of abnormal red blood cell staining is the polychromatic. Erythrocyte stains blue-gray as a consequence of uptake of both eosine and basic dyes, often slightly larger than normal red blood cells and round in shape. It can be found in bleeding or hemolysis. Red blood cells that have just been denucleated but not fully mature are slightly larger than normal red blood cells. Its increase reflects the proliferation of bone marrow erythroid, which is common in hemolytic anemia. Now let's learn abnormal structure of red blood cells. First is the basophilic stippling cell. That's very fine, pinpoint cytoplasmic granules distributed evenly in the cytoplasm. Its increase indicates that the erythroid hyperplasia in the bone marrow is vigorous, which is seen in lead poisoning, and can also seen in megaloblastic anemia or hemolytic anemia, liver disease, and etc. The next kind of abnormal structure in red blood cells is the Hodgkin's body. It is round chromatin fragments remaining in the cytoplasm of mature erythrocyte, resulting from abnormal division of erythroblast. It increases in the post-splenectomy, megaloblastic anemia, and erythroleukemia, etc. The next kind is the Cabot ring. It's it's loop-shaped or the number 8 shaped. It is the spinal residues in the plasm, and it increases in severe anemia, lead poisoning, and erythropoiesis. The last one is the nucleated erythrocyte. It exists in the bone marrow. Because the nucleated red blood cells in adult peripheral blood are pathological pneumonia. If we can see the nucleated erythrocyte in the circulated blood, that means that can be seen in the hemolytic anemia, erythroleukemia, extramedullary hematopoiesis, such as bone marrow fibrosis, bone marrow metastatic cancer, or severe hypoxia. Now let's learn the abnormal morphology of neutrophils. I'll explain this part from the three aspects. First, toxic change, and then hypersegmentation, and the last, abnormal morphological change related to heredity. And this picture shows the toxic change in neutrophils. It contains 4 kinds: toxic granulation, vacuolization, dual body, and degeneration of nucleus. The first, toxic granulation, I show it in green. It's dark blue or purple granules in the cytoplasm. Yeah, I show it in green. The green arrow shows. While dual body, I show it in blue. Yeah, this one. And can you see that? That's the dual body. Dual bodies are small, blue, round, or oval structures in the cytoplasm of neutrophils. There are specific areas rich in RNA and caused by abnormal cytoplasmic maturation due to toxicity. The next one is the regularization. Regularization as shown in the dark red. Yeah, like this. This shows. Can you see the regularization? Yeah, in the cytoplasm, the regularization it is a vacuous or colorless or granular space which contains enzymes necessary to destroy bacteria. Yes, and the last kind is the degeneration of nucleus. I show it in the black arrow. Yeah, the black arrow shows here. Yeah, can you see that? Yeah, it is the nucleus degeneration. All these toxic changes can occur in severe infectious disease, such as purulent infections, sepsis, malignant tumors, poisoning, and extensive burns. And this two pictures shows the morphology of neutrophil. The left one is a typical segmented neutrophil, and the right one is a megaloblastic granulocytes. We all know the diameter of mature neutrophils in a normal blood is 10 to 13 micrometer, and the shape of the cell is round, and the color of the cytoplasm is pink or orange under the rich stem. The nucleus of neutrophil are subdivided into a number of lobes, usually 3 to 5 lobes, just as the left picture shows. And uh, these two pictures shows another abnormal morphology of leukocytes. The neutrophil nuclear incompetence, or we call it the Pelger-Hughes anomaly. The morphology of the neutrophil nuclear incompetence is it is a genetic disorder, and the main feature is that the nucleus of neutrophil is bilobed or hyposegmented, and chromatin is coarse and the cytoplasm is pink with normal granulation. It can be seen occur in the hereditary disease, some infection disease, myelocytic leukemias, and myeloproliferative syndromes. Here, I want to show you one definition, nuclear shift of the neutrophil. Refers to the neutrophil nuclear lobes, which reflects the maturity of the neutrophil. Neutrophils in the peripheral blood of normal people are mostly 2 to 3 leaves, mostly less than 5 lobes, but a small number of stem neutrophils, usually less than 5%, can be seen in peripheral blood. We call it the nuclear shift. First is the nuclear shift to the left. Peripheral blood contains more than 5% of non-differentiated leaf nuclear neutrophils, including stem neutrophils and previous immature neutrophils. It can be seen in acute purulent infection, acute blood loss, acute poisoning, and acute hemolysis. Extreme shift to the left of the neutrophil nucleus is common in leukemia and leukemia-like reactions. Significantly left shift of neutrophil nucleus, but low white blood cell count often indicates severe infections. And the picture shows the this fourth stage of the development completion of white blood cells only in the bone marrow. Only these two types of white blood cells may appear in peripheral blood. Shift to the right. It means more than 3% of neutrophils in the peripheral blood have nuclei with 5 lobes or more, mainly seen in megaloblastic anemia, pernicious anemia, and inflammation recovery period. If shifted to the right of neutrophil nucleus, suddenly in the progress stage of the disease, it indicates a poor prognosis. And the picture below shows the shift to the right. We can see these leukocytes have the nuclei with more than 5 lobes. Okay, now let's learn this third part, reticulocyte. Reticulocyte. The picture I show in the upper part is the red blood cell production process. The a red blood cell from human stem cells in the bone marrow to mature erythrocytes, from large to small ones, and the reticulocyte is the transition stage before the mature erythrocytes. It is there are red blood cells that are not yet fully mature, and transitional cells from denucleation to fully mature erythrocytes reflects the production capacity of red blood cells in the bone marrow. There are still basophils, such as ribosomes, in the cytoplasm of reticulocytes. After staining with brilliant tar blue or near methylene blue, the reticulocyte show a light blue or dark blue network structure. so we call it the reticulocyte. As the picture shows, yeah, these two red arrow shows this cell, and it's the reticulocytes. We stain it with a brilliant top blue or near methylene blue. Well, the reference range value of reticulocyte is the percentage is 0.5% to 1%, and the absolute number is 24 to 84. What's the clinical significance of reticulocytes? Under physiological conditions, only a small fraction of reticulocytes is released into the peripheral blood. The number of reticulocytes is expressed as a percentage of the total number of erythrocytes counted in the peripheral blood. We usually use the reticulocytes to screen for hemolytic anemia and red blood cell reduction disease, and to monitor change in bone marrow hematopoietic function after radiotherapy, chemotherapy, or transplantation. Increased reticulocytes means that an increased reticulocyte count in the peripheral blood is a reliable indicator of regenerative erythropoiesis, that which is seen in hemolytic anemia, acute blood loss, etc. After the bleeding stops, the reticulocytes gradually return to normal. While decreased reticulocytes, it means reduction of erythroid hyperplasia in the bone marrow, which can be seen in aplastic anemia, hemolytic anemia, reproductive crisis, acute leukemia, and hypoplasia of bone marrow hematopoietic function caused by certain chemical drugs. Erythrocyte sedimentation rate, short for ESR. ESR refers to the distance that red blood cells in isolated anticoagulated whole blood sink at the end of the first hour under certain conditions. ESR measures how quickly red blood cells cell in a test tube in 1 hour. It is a common hematology test. To perform the test, anticoagulated blood was traditionally placed in an upright tube known as a Westergram tube, and the rate at which the red blood cells fall was measured and reported in millimeter per hour. Now, the ESR test can also be performed by automated analyzers. The reference value of ESR for male is less than 15, for female is less than 20. But ESR is affected by many factors. First, Rolox formation of red blood cells is the most basic influencing factor. And the changes in the protein composition of plasma can also affect the ESR. The increase of globulin and fibrinogen leads to accelerated ESR. Number and shape of red blood cells can also affect the ESR. Reduced red blood cells lead to faster ESR. Increased spherical red blood cells lead to slower ESR. The ESR is a non-specific test. In many pathological conditions, ESR can increase significantly. Considering its result in conjunction with other clinical data, there is still certain reference value. So what are clinical significance of increased ESR? First, physiological conditions associated with increased ESR, such as old age, female pregnancy, and so on. While pathological conditions, first is the inflammatory disease, acute bacterial inflammation, rheumatic fever, tuberculosis, and etc. It is used to observe the activity of the disease. Next, the second is tissue damage and necrosis. It can be seen in large tissue damage, surgical trauma, tissue necrosis caused by organ infarction, etc. ESR can help distinguish between functional and organic disease. For example, ESR increases in myocardial infarction, while ESR is normal in angina. And tumors. Malignant tumors have increased ESR, and benign tumors are usually normal. When the treatment of malignant tumor is obviously effective, ESR tends to be normal, and it can increase when recurrence or metastasis. Hyperglobulinemia caused by multiple reasons, such as multiple myeloma, macroglobulinemia, malignant lymphoma, etc. Others, anemia, hypercholesterolemia, and so on. Now let's learn the CRP. It means C-reactive protein. CRP are the proteins that rise sharply in the plasma when the body is infected or tissue damaged. The reference value of CRP is less than 10. What is the clinical significance of CRP? It can be used to identify bacterial or viral infections, or it can be used to monitor the activity and the severity of the disease, or instruct antibiotic treatment and monitor the effect. And this table shows its clinical application of CRP. For child, we can see if the test result of CRP is less than 10, it means the clinical significance is that when the cause of the disease is greater than 6 to 12 hours, then bacterial infections can be basically ruled out, or the bacteria have been eliminated. While the test result for children of CRP is between 10 to 25, it may indicate viral infection, or CRP value should fall below this level during antibiotic treatment. If the cause of the disease is short, the bacterial infection cannot be ruled out. It should be rechecked after a few hours. If the test is more than 25, it indicates bacterial infections. For adults, if the CRP is between 10 to 25, it indicates the viral infection, or maybe the CRP value should fall below this level during antibiotic treatment. If the cause of the disease is short, the bacterial infection cannot be ruled out. It should be rechecked after a few hours. And if the result is between 20 to 50, it means bacterial or viral infections. If the test is between 50 to 100, usually it is bacterial infection. Viral infection is rare. While it's more than 100, it means a severe bacterial infection. Viral infection can basically be ruled out. Here there's another CRP. We call it high sensitivity C-reactive protein. Here I want to ask you guys, does CRP is the same with high sensitive CRP? Are they the same thing, or are they the same substance? The answer is yes. HS-CRP, the reference interval of HS-CRP is 0 to 5. HS-CRP, high sensitive CRP, is not a new CRP. The true CRP detects the same substance, C-reactive protein, but just the HS-CRP is used to assess the risk of cardiovascular disease. Okay, the next, PCT. PCT is a protein when the body is severely infected by bacteria, fungi, parasites, sepsis, and multiple organ failure. The content of PCT in plasma increase. PCT reflects the active degree of systemic inflammation. The reference value of PCT is less than 0.05. The clinical application of PCT, we can see the table below. If the result of PCT is less than 0.05, it means the body is healthy. While the result is is less than 0.5, maybe there's a local infection. While the PCT is less than 2, maybe there's a systemic infection like sepsis. While PCT is less than 10, between 2 to 10, maybe there's severe sepsis. While more than 10, maybe a septic shock. Okay, now until now, any question? If any question, maybe you can think it and send me an email. Now let's learn the next part, laboratory diagnosis of anemia and the related red blood cell disease. First concept of anemia. Anemia refers to a symptom in which hemoglobin, red blood cell count, and hematocrit in a unit volume of peripheral blood are below the lower limit of the reference interval for people of the same age and gender in the region. Anemia is not an independent disease, but a clinical syndrome. It is a common symptom of many diseases. The table up shows the classification of anemia by hemoglobin. The anemia can be classified as mild anemia. The hemoglobin is between 90 to 120 and 20 for adult, while for female is 110. Medial moderate anemia is the hemoglobin between 60 to 90. Severe anemia, the hemoglobin is between 30 to 60, and extremely severe anemia, the hemoglobin is less than 30. And the table below shows the diagnostic criteria for anemia in China. There are 3 kinds of classification ways of anemia: etiology and pathogenesis classification, morphological classification, and classification of bone marrow hyperplasia. In this class, we'll just learn the morphological classification. This picture shows the etiology and pathogenesis classification. You guys may learn it after the class, okay? And this picture shows morphological classification of anemia. Here, red blood cell parameters MCV, MCH, and MCHC can help us to turn the anemia morphological classification. There are 1, 2, 3, 4 types of anemia. There are normocytic anemia, macrocytic anemia, microcytic anemia, and microcytic hypochromic anemia. The normocytic anemia can be seen in aplastic anemia, acute blood loss anemia, and hemolytic anemia. While macrocytic anemia can be seen in megaloblastic anemia, microcytic anemia can occur in anemia of chronic disease, and microcytic hypochromic anemia occurs in iron deficiency, sideroblastic anemia, or hemoglobinopathy. Here you guys should pay attention to the red bars. That's the important information for the final test. Okay, let's learn iron deficiency anemia. Iron deficiency anemia is an anemia caused by lack or exhaustion of iron storage in the body and the disorder of red blood cell production. The red blood cell smear shows microcytic hypochromic anemia, and the patient shows depressed nails. The cause of iron deficiency is the key information for diagnose the iron deficiency anemia. It can be caused by increased iron demand or loss or decreased iron intake, and can occur in both children and adults. The cause of chronic blood loss should all be considered according to the patient's sex, age, and history, and anemia without an attributable underlying causes is sufficient for an urgent referral to exclude underlying malignancy. The blood smear of a patient with iron deficiency shows many hypochromic and rather small red blood cells, and may also show variation in shape and anisocytosis. With more severe iron deficiency anemia, the peripheral blood smear may show target cells and occasionally small numbers of nucleated red blood cells. Next kind of anemia is megaloblastic anemia. Megaloblastic anemia, it is a type of anemia that is caused by a decrease in vitamin B12 and or folic acid intake, or an increase in demand or utilization disorder, resulting in disorder of red blood cells DNA synthesis. The common feature of MA is that the MCV and MCH of peripheral blood red blood cells are higher than normal, and megaloblasts appear in the bone marrow. And these three pictures shows the blood picture of MA. We can see the red blood cells and the hemoglobin were reduced. The red blood cells obviously vary in size and are large oval with giant red blood cells, stippling red blood cells, and peribody and nucleated red blood cells visible. The white blood cell count can be reduced, and the nucleus of the neutrophil nucleus shifted to the right, and the platelet count is reduced, and huge platelets are visible. That's the huge platelet. They come together. Next kind of anemia is aplastic anemia. Aplastic anemia is an anemia characterized by bone marrow hematopoietic failure caused by chemical, biological, physical, or unknown reasons. The main clinical manifestations are anemia, infection, and bleeding. The blood picture of aplastic anemia. Please remember, red blood cells, white blood cells, and the platelets are all decreased. Red blood cells and hemoglobin decreased in parallel, showing normocytic anemia, and the reticulocytes decreased. Leukocytes are reduced, and the proportion of lymphocytes increased. Platelets are significantly reduced. Here, there's some supplement information. The structure of hemoglobin. Our normal hemoglobin is composed of 2 alpha globin chains and 2 beta globin chains, each combined with a helix. These 2 globins are encoded by the corresponding alpha globin gene and the beta globin gene. We all know that the cytoplasm of erythrocytes is rich in hemoglobin, the iron-containing biomolecules. So the hemoglobin can bind the oxygen, and it is responsible for the red color of the cells. And a normal human hemoglobin composition, I write it in the gray box below. Here I want to explain the thalassemia. It is an inherited hemolytic disease caused by the decline or loss of the function of the globin gene. We call it the thalassemia. Due to one or more deletions or mutations in the globin chain gene, the synthesis of one or more peptide chains is missing or reduced, resulting in insufficient hemoglobin production and producing microcytic hypochromic anemia. Blood transports oxygen and nutrients to cells and tissues, and at the same time removes waste materials and carbon dioxide. In addition, it plays a vital role in our immune system and in maintaining a relatively constant body temperature. The visible components of blood include the red blood cell, white blood cells, and platelet. Blood routine examination mainly include blood cell count and hemoglobin concentration, and some blood cell parameters like MCV, MCH, or MCHC. Um, Sometimes also includes erythrocyte sedimentation rate. Um, mm, in addition, there are some other laboratory indices are helpful for blood tests like CRP, PCT. These two indices is inflammation indices marker or marker. And last, we learned anemia. We know there are three kinds of classification methods for anemia, and we just learned the anemia for the morphology classification. That's the all knowledge of this class. And if any question, please send me. Finally, this is my email. Any question about this class, feel free to send me the email. Okay, thank you.